All right. So who are you? Some people call you Wolfie.
Yeah, some people call me Wolfie. Yeah, yeah. Shall I tell you whom I am? Yeah,
Yes.
yeah.
Why not?
I'm Wolfgang Reinpold. I'm a hernia surgeon from Hamburg, and I run a quite busy hernia center there, the Hamburg Hernia Center, together with my partner Henning Niebuhr. We perform about 3,000 hernia operations per year. I've been very active and busy in the field of hernia surgery in the last decades. I was president of the German Hernia Society from 2014 to 2020, and I'm on the board of the European Hernia Society as a secretary for teaching and education.
Well, that sounds like a half impressive CV. So, just kidding. Well, you are famously known as the inventor of the Milos operation. Now, I would like to ask you a very specific question, given that it is structurally a sound operation in that you're putting in a retrorectus mesh, you're closing the defect, and where is the problem with the operation, you think? Why is that operation not a gold standard everywhere? Why isn't it more popular than it deserves? What are your views on
Yeah,
this?
that's a good question. I think for many years the laparoscopic IPOM technique was the gold standard of ventral incisional hernia repair. I was always convinced that the mesh inside the abdominal cavity is not the right place. So I was always thinking about alternatives to get the mesh out of the abdominal cavity. You know, and when I asked surgeons at the hernian Tage in Germany, a big hernia meeting in Germany, which I organize every year. Everybody was convinced that lap IPOM is a very good technique, but when I asked if you had a hernia, a ventral hernia, what kind of operation would you like to have, and only one or two answered, I would like to have a laparoscopic IPOM. So I was looking for new ways for many years, and first, as you know, I started to develop the laparoscopic transabdominal retromuscular mesh repair via the left flank, published in 2013. Good results, but a difficult operation with straight sticks. So I thought the minimal invasive transhernial approach might be a good option. And when you start to do the operation in that way, I think it's difficult for laparoscopic surgeons who formerly performed lap IPOM to convert to this operation, because in the beginning of the operation it's a mini open access, and it's not a laparoscopic operation at the beginning. So this is why, I think. And on the other hand, at least in Germany, many surgeons who formerly did open supply repair, they convert to the Milos or endoscopic Milos approach much easier, because they see that they have to reduce the incision and do essentially the same operation as they did with a large incision in a minimal invasive fashion. So essentially, in my opinion, Etap and Milos, endoscopic Milos, are the same operation, and you can decide in every patient which access you will use at the beginning. So sometimes I use the Etap approach, for example, when I operate on Spigelian hernias. I think the Etap approach is the best.
And you use the stapler freely when you're doing a Milos, am I correct?
The stapler?
Yes.
No, I never use the stapler.
You never use the stapler, but there are people who use the stapler for coalescing the two retrorectus compartments.
No, I never do that. My standard is that
Suture.
I open the posterior rectus sheath, of course, but I leave it open. I don't approximate the posterior rectus sheath. I close the peritoneum in between the cut edges of the posterior rectus sheath, but essentially is to close the anterior fascia, the hernia defect. So I close the posterior rectus sheath only very rarely. Let's say in women with a diastasis recti, then sometimes I do it, but only if it's possible with a very with very low tension.
Okay. Another thing which you're very well known for is your cadaveric study on the nerves. That is pretty much a standard slide, I think,
Yeah.
in every one of the chronic groin pain talks and the laparoscopic inguinal hernia talks. So, what is basically, we could call it the final conclusion of your study? A lot of the people watching this may not have read your paper, but this might encourage them to go through your paper. And so, could you tell us basically what you found? What is your understanding about the subject that is important clinically?
So the study deals with the posterior anatomy of the lumbar plexus, and we did it. The first intention was we wanted to know the cause of the iliohypogastric, the ilioinguinal, the lateral femoral cutaneous nerve, and the general femoral nerve, of course. And we wanted to know where these nerves can be found if you try to do a laparoendoscopic neurectomy. And the important finding is that the variability of the nerve causes is very high in the periphery. But in the proximal part, it's almost always possible to identify the trunk of the iliohypogastric nerve and the ilioinguinal nerve on the quadratus lumborum muscle. This is the most important message. So if it comes to endoscopic preperitoneal neurectomy, you can identify the nerves there on the anterior surface of the quadratus lumborum muscle. And if it comes to the neurectomy of the genitofemoral nerve, the genital branch and the femoral branch, you can identify this nerve on the psoas muscle. So in the periphery, it's very difficult. So in my experience, the retroperitoneal endoscopic approach is best. The laparoscopic transperitoneal approach does not give you this good of overview over the
You're talking about approaches to what? Approaches to the hernia or to neurectomy?
To the
neurectomies. Okay.
And on the other hand, the study showed us where the nerves are, and if it comes to TAPP or TEP repair, TAPP is my standard procedure for inguinal hernias. It is interesting to know where the nerve branches might be. So if it comes to mesh fixation, you have to be very careful, even more careful than I anticipated before our trial. If it comes to traumatic mesh fixation. So in other experience, we fixate the TAPP mesh only with one little stitch at Cooper's. This is a standard in our institution. We just want to avoid that the mesh slips in the early phase, in the early postoperative phase.
So today, with so many years and so many thousands of cases under your belt, what is your approach to neurectomies? Do you do a lateral Etap, or do you go open, or how do you approach?
It depends. If it's chronic pain after an anterior operation, then I do open triple neurectomy. If it's chronic pain situation after laparoendoscopic operation, then we do the retroperitoneoscopic approach via the flank.
Okay. Like we used to do it for urology back in the day.
Yeah, like you do, for example. I learned the technique from a famous surgeon in Austria who performed sympathectomies.
Okay.
Retroperitoneoscopic.
Right. This was, I don't know if you know it.
Professor Riga.
Okay. Originally, retroperitoneoscopy started off for urology back in the 90s by an Indian urologist called D.D. Gaur.
Ah, yeah, interesting.
Yeah. Anyhow, thank you so much,
You're
Wolfgang.
welcome. Ram, it was great talking to you.